Everyone. Thank you for joining us once again for our weekly briefing on preventing and managing COVID-19 in the workplace. This is Karen O'Hara. I'm the Director of Marketing and Communications with WorkCare and your moderator for today's session. This is our 50th consecutive week, so we welcome you back if you've been a regular attendee, and if you're just joining us for the first time, you'll see that we follow the same format from week to week. The session is being recorded and you'll be on mute during the webinar. Please use the Q&A function in Zoom to submit your questions, and we'll take all the questions at the conclusion of the presentation. We also transcribe answers to all questions, including those we don't have time to address, and post the answers on our website on the COVID-19 page, which you can find at workcare.com. We post the recording on our YouTube channel. During the webinar, we'll post links to both of those resources. Our speaker is Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's WorkCare's Chief Innovation Officer and Associate Medical Director. He's also our lead clinician for WorkCare's COVID-19 response. And after 50 weeks, I feel like you probably are all getting to know him pretty well and really have learned to appreciate his expertise and ability to keep up with all the latest with COVID. So I'll turn it over to him. Thanks again for joining us.
Excellent. Thank you, Karen. And thanks everyone for joining us once again. We'll go ahead and jump into our regularly scheduled format for our 50th session here. So today we have a interesting topic, a little different from usual, obviously related to COVID, but we are going to talk about today for our clinical encounter something that has made a presence over the last, I'd say, 8 to 10 years, and is making a resurgence here recently with the advent of COVID. And I know it's a little cliffhanger, but we'll uncover what it is here shortly. So our format, as usual, starts with our clinical update, followed by our microbiology, our pathology, kind of digging underneath the causal associations behind what we consider week to week. And then we'll talk about the epidemiology, how we're doing with regard to COVID, both US and globally, followed by our preventative trends, right? Our prevention trends that we need to be cognizant of, and recommendations that WorkCare has in regards to protecting our workforce. So today we're talking about addiction, and we're talking about opioids in particular. So I know it's a little deviation from what you would typically expect because we're not talking about specifically clinical manifestations of COVID. However, we know that the pandemic, has been a deeply impactful phenomena on mental health. And mental health in association with opioid use has been something that we know to be a causal, in some cases, increased risk as well. And we want to get into that because these are things that are going to be germane to protecting your workforce as a result of COVID and the impacts of COVID from a mental health standpoint and an addictions and even substance abuse and overdose standpoint. So you've seen this in the news recently, most likely, right? Overdoses that have accelerated during COVID-19. And this data has been tracked over the last 12 months, and 81,000 drug overdoses in 12 months represents the greatest number of overdose deaths ever recorded, right? And CDC has published this information because it is alarming in regards to the impact that not only this will have in regards to opioid use amongst the general public, but obviously the workforce is important to undergo a deep dive and understand how this is going to impact the workforce, not just now, but in the months to come and potentially years to come as a result of COVID-19 pandemic. So when we talk about overdoses in 2019, we see an increase since then of these overdoses in basically all the states at this point in time. And we know that one of the drivers CDC has published of the overdose phenomenon has been fentanyl, a synthetic opioid, and the actual number being an increase of 38.4% over the last 12 months since June 2019. Okay. And if we look at the months leading up to that, we can see a trending up of overdoses in general before COVID, and that accelerated during COVID. What we also saw in general was that those synthetic opioid states, right, jurisdictions, 37 out of 38 of them reported increased utilization or increased use and increased deaths in those jurisdictions, right? We looked at 18 jurisdictions that increased over 50% in regards to overdose deaths, and 10 Western states actually reported 98% increases in synthetic opioid deaths. So again, deeply impactful to the community, to the workforce potentially, and something we need to plan for if we haven't already built in a process for helping these workers. And we'll talk about the other impacts, not just from a loss of life, but also from a workplace productivity, absenteeism, presenteeism, et cetera. So when we talk about the other overdose associated deaths, cocaine has seen an increase, 26.5%. We've seen an increase with methamphetamines and other psychostimulants increased by 34.8%. So again, it's not limited to only synthetic opioids, but again, opioids are perhaps some of the most alarming because of a number of factors in terms of ease of access. And so we want to talk about the clinical presentation of individuals that may have symptoms or signs rather of addiction to opioids. Some of the things to look out for are changing of friends or groups of workers that they hang out with, right? Associate with at work, spending more time alone from family, friends, work, coworkers, loss of interest, not bathing. So if your coworkers notice, an odor, or if they notice individuals being more disheveled than they are normally, these are things we want to train our coworkers on, our workforce on, to identify and to not be afraid to, raise a flag, right, appropriately to supervisors. Changing in energy level, being very tired, very sad, change in diet, eating more than usual, right? And then the loss of energy, loss of interest, being nervous, having signs of anxiety, mood swings, mood changes. So the list goes on. Several things that we need to build into our programs to look out for. We'll specifically call out here as we continue through the presentation. But again, we want to present practical things that the workforce needs to know to identify individuals at risk so that, again, we can hopefully keep people safe and keep the workforce productive. So we would be remiss if we didn't talk about the symptoms of an overdose that occurs at work, right? We know that some programs are in place with workforces to deal with potential overdoses. We'll talk about those specific program facts shortly as well. But pay attention to slow, shallow breathing, right? Those things that need immediate attention, extreme sleepiness, obviously inability to talk or changes in color of the skin, lips, and then snoring or gurgling sounds, right? If someone is in a stupor, if you would, at work. All symptoms that need to be addressed immediately and obviously activate whatever workplace emergency system exists for you all. So when we talk about the drivers, right, that's what we're going to address when we speak to the phenomenon that we're seeing now with regard to overdose and increased utilization of opioids during the COVID pandemic. When we talk about the trends and drivers, historically, we've seen a decrease in the opioid dispensing in the U.S. over the last couple of years. It increased as we track since 2006, right, up until 2012, where it peaked at 81.3 prescriptions per 100 people. Okay, and this is a marker that is used and has been used to track, again, rates of prescriptions being written by clinicians in the US and the associated increase in utilization and addiction, overdose, misuse, etc. All right, so so the number has decreased since 2012, but still a significant number, up to almost half, right? So 46.7 prescriptions per 100 individuals. So if we talk about then some mental health and opioid associations, this data, a lot of this data stemming from 2017, 16% of Americans that have mental health disorders receive more than half of opioid prescriptions. Okay, so that's telling in terms of the association between mental health and opioid prescription and dispensing in the U.S. If we look at then the increased risk factors such as mood disorder and anxiety disorders, 2 times increased likelihood of use of opioids if you have either of those disorders, right? And we're talking about misuse of opioids. The mood disorders and anxiety represent a 3x increase of misuse of opioids. And so we've talked about in this program before the increases that we've seen in mental health as a result of COVID-19, a 3x increase in mental health disorders in the US, right? And so we know that COVID is impacting workers significantly. We know that workers statistically are going to be at increased risk as a result of those mental health disorders, depression in particular, for opioid use. And we'll talk about the impacts that will likely have on our workforce in terms of, again, absenteeism, presenteeism, and the true costs associated with this phenomenon, again, driven by COVID-19 as a result of the pandemic. So when we look at depression specifically and prescription opioid misuse, we can see some data pointing to the association of increased risk of misuse as a result of depression. Okay, and if we look at this particular study published back in 2012 in the Annals of Family Medicine, the study looked at 1,300 patients, and these were patients that didn't have pain from cancer. Okay, that's important because that's a marker of chronic opioid use that we didn't want included in this study. And if we look at the determinants in terms of misuse definition, there were 3 criteria used. So one of them was self-medicating for symptoms other than pain, self-increasing of doses, and then finally giving medications like opioids from one person to another or receiving medication opioids from someone else. And so the results were telling, right? If we look at individuals who were not depressed and compare them to individuals who had moderate or severe depression, those with moderate or severe depression had a 1.8 to 2.4 times more likelihood of misusing opioid medications. All right. And so, again, going back to our association of COVID-19 having a 3x increase in depression and other mental health disorders, we know there's significance in terms of impact to our workforce as a result of the COVID pandemic on both mental health and opioid utilization and misuse. And then patients with mild, moderate, or severe depression, again, 1.9, 2.9, and 3.1 times more likely, respectively, than those who did not have when we were looking at those who specifically had self-increasing dosages for the marker in particular of misuse. If we look at then the individuals when we reported those individuals who were sharing medications, either giving or receiving medications, there was no significant difference between those without depression and those with depression. So not a risk factor there. As we then go on to talk about the performance in the US and abroad of COVID-19 prevention, we look at our epidemiology week over week. So let's jump into those numbers now. 27 million cases last week is what we reported. This week, 27.9, okay, million cases, almost 28 million. But the rate here is significant to pay attention to, right? 25.9 is where we were at per 100,000 over a 7-day rolling average, dropped down to 19.3. So we've continued to see a downward trend in the data for cases in the US. If we look at deaths, we also see a downward trend. We were at 0.9 per 100,000 in a 7-day rolling average, dropped down to 0.6, right? So we're seeing those decreases happen across the board, basically in all states at this point in time. If we look at then globally how the US is faring, we saw last week, number of cases again decrease on a 7-day rolling average. And we see that trend kind of level off a little bit, even though we're overall still decreasing this week compared to our counterparts. Again, they're seeing decreases and leveling off as well. From a per million people, cases per million, we see decreases across the board. From Israel to France last week, in the UK and US, we see those trends continue. Italy had a little bump, but again, overall decreasing trends is what we see across the board. If we look at then the number of the 7-day rolling average for deaths on a daily average, we can see the US was decreasing last week, along with other nations, and seeing a small little increase from last week to this week. But again, we anticipate that will continue to decrease along with the decreasing rates as we move forwards. Likewise, we're seeing decreases across the board in other nations. Per million, again, decreasing last week, decreasing this week. And so we'll continue to pay attention to these trends. And we anticipate, again, as we get going with increasing vaccinations, that these rates hopefully will continue to trend lower. If we look at testing, we were trending down and have been trending down for several weeks now, while other nations were plateaued or trending up, except for India here. And if we look at this week where we're at, we're continuing to trend down. Other nations are plateaued for the most part for their testing on a 7-day rolling average. If we look at per 1,000 individuals, same picture we see in terms of trend. US last week trending down here and continuing to trend down per 1,000 individuals, as well as in other nations as well. So this global picture of downward trend of both rates and deaths, as well as testing, all speak to not a phenomena we're seeing in terms of an aberration in the data as a result of something occurring in the environment, or something happening from a standpoint of misrepresenting the true number of cases. It likely, because we're seeing it globally, is a true representation of a decrease in the incidence of COVID-19 in the general population. Okay, so that obviously is a good indication or a good sign of where we're heading globally from a impact of COVID-19. Now, will that trend reverse as we enter warmer months? It may, as people get out and about more frequently in the northern hemispheres, but we have yet to see those rebounding trends at this point in time. If we look at then the percentage of positive cases, we're seeing then a decrease in this metric. Again, that's heading in the right direction when we see a decrease in percentage positivity rate. And we're continuing to see that decrease overall across the board. And again, pointing towards more accurate depiction of the impact of COVID-19. Vaccination-wise, we're continuing to see our numbers increase here in the US. They're plateauing in the United Kingdom on a 7-day rolling average, and other nations as well. And we'll see this week a slight decrease in a 7-day rolling average for vaccinations. That likely is a bump downward from the supply gap that we know existed here in the last couple weeks. But we'll look more deeply at the vaccination rates here in a second. So when we talk about per 100 people, again, Israel still in the #1 spot there, United Kingdom, and then US last week, and we'll see that trend continue this week as well. So the exact numbers of vaccinations here in the US, we went from 71 million with Pfizer leading Moderna here for delivered doses to this week, different representation of the data here, but up to 82 million doses, and then administered doses, 65 million. All right. And we're talking about 44.5 million receiving one dose, only 20 million, roughly 19 million, a little over 19.8 million receiving both doses. Again, both doses necessary to declare someone immunocompetent from a standpoint of efficacy of that 95 percentage, right, for the Pfizer and the Moderna. So we have a ways to go to get those second doses out to those individuals, and as we compare to those who received the first vaccine, and we'll continue to watch this to see if that gap narrows. When we talk about Pfizer versus Moderna, Pfizer still being leading by 2 million doses approximately for administration of the vaccine here in the US. We'll note at this point in time that FDA this week is entertaining Johnson & Johnson. We've talked about Johnson & Johnson in the past. It is a single dose that is being contemplated by FDA, and we'll look for whether or not Johnson & Johnson will be the next approved vaccine. It's anticipated that if they receive emergency authorization, there are 2 million doses that are ready to go for Johnson & Johnson immediately, and from Johnson & Johnson immediately. And there are 20 million doses that will be distributed before the end of March. So that is obviously good news to help with the supply gaps that we've seen. And we know the numbers of vaccines secured by the federal government are going to be in the hundreds of millions. So 200 million is what's purported by the Biden administration. If we look at then the tracing of the variants, we paid attention to this last week here, looking at B117, B1351, and P1, again, the UK, the South African, and the Brazilian variants here. We can see where they were last week. And if we look to where they've expanded to this week, we see increasing in number of states. All states now reporting, right, cases for the most part in the Midwest and the coast. We still have the several states that have 0 cases of the variants thus far, but most states have reported, and now we have increased numbers in Michigan and several other states. So we'll pay attention to this because we've talked about the impact of the variant, the potential for the variant in the South African variant to be slightly resistant a bit to the vaccines that we've seen. But again, we're not getting any substantial reports yet of the variant escaping significant numbers of individuals that have been vaccinated. As we then get back to our prevention trends for opioids now, right, and the impact from COVID-19 with mental health and the confluence of opioid utilization and overdoses, we can see the impact that it might have to the workforce. And when I say might, that means it likely is, right? Because we have objective data demonstrating increases in overdoses, which means utilization or misuse and abuse is also up as well in terms of opioid opioid addiction potentially, right? And so if we talk about then the impact to employers of opioid addiction, this is undergirding why we need to pay attention, if we haven't thus far, at programs targeting interventions for the workforce and hopefully interventions that span beyond the walls of the workplace for helping in the community. And when we talk about the impacts of opioids on the workforce, the impacts start with absenteeism, right? We know that the absenteeism in the workforce is about 3 extra days per year equivalent, right? So if there is opioid utilization compared to those who don't have a prescription for opioids, the average is 3 extra days for absenteeism. Right. And then this is higher than heavy alcohol use. So that's something to note. $1.1 billion is a little dated in terms of the data, but still significant. So we know the number is likely to be a little higher in comparison, but $1.1 billion due to absenteeism as a result of opioids, okay, utilization in the US. If we look at healthcare costs, they are substantial, right? And if we look from 2007 to 2014, we can see that insurance, private health insurance for opioid dependents soared, right? 3,200%. 3,200%, right? Obviously, that's a huge number here. And we know that if you're self insured, you're bearing the cost of that, right? Not just the private insurance is impacted. And that's, again, another reason why we need to have attentiveness to the impact during this pandemic. On average, a person at risk, people with at risk opioid use, right, possible addiction, cost employers nearly twice as much in healthcare costs, right, than those not at risk. And then if we expand that, we can see that even family members have an increased risk of costs or increased costs on employers if they have a family member with opioid addiction. Okay, so again, self insured employers have to pay attention to the impacts of opioids as a result of mental health, as a result of COVID, because it's going to hurt not just the true cost of healthcare. It's going to hurt the productivity from an absenteeism, presenteeism, turnover as well. And obviously, it'll hurt the bottom line from a productivity standpoint. So if we look to other data pointing to the use of opioids, the opioid disorder, and the impact in the workplace, this study that was published in JAMA, right? Excuse me, this was published in the Journal of Occupational Medicine, JOEM. So we want to look at the results from this study, particularly around the cost associated for opioid utilization, right? And those who received pharmacotherapy as a intervention for opioids cost far less, 629 or $6,294, compared to those who had healthcare costs associated with their opioid addiction and utilization at 21,000, right? So again, this is a study that allowed us to understand that providing interventions, providing means to help individuals with opioid associated consequences can actually save the company money, particularly if they are self-insured, right? So, in conclusion, obviously, then this is a business case for having a program in place for opioid addictions, opioid misuse as well. So the strategy, pretty straightforward, right? When we're talking about what do you do in the workplace for opioids, what are the considerations? The considerations are to potentially put a program in place, right? And that program is nothing too out there, right? It's not something that hasn't been examined and hasn't been published in regards to how we can effectively, as an employer, put a program in place to address opioid addiction, opioid use. One of the interventions, obviously, is in the workplace providing a naloxone program, right? And naloxone, if you're not familiar, is a medication that is used to help prevent death, essentially, during an overdose scenario. So it can reverse the health effects, the immediate health effects of a opioid overdose, right? And this program obviously is not in isolation. This program is in concert with a communication internally in the workplace to address and to destigmatize opioid abuse, opioid addiction, opioid misuse, right? And so it's a campaign that brings awareness to the workforce that yes, we know that there are impacts from COVID-19 as a result of mental health impacts to opioid utilization, and we have programs in place to help you. Right. And so that's the goal. NIOSH has published a really good roadmap for putting a program in place and considerations. Risk assessment is key, right? So deciding whether or not the program is right for your workforce, right? And also deciding who are going to be the key stakeholders in the program is a strong consideration, not just for your HR, but obviously for legal as well. And then training, focusing on training so that we can address to the workforce, what do you look for, right? What are the signs? Should you be concerned with the coworker who presents with some of those signs that we mentioned earlier? And what do you do about it? What are the steps, step A, step B, step C necessarily, to help that individual, that coworker that may be at risk, right? So we want to, again, communicate effectively the notion that it's okay, and here's the process to verbalize a concern for a coworker that may be suffering from an opioid addiction or opioid misuse. All right, and with that, we're gonna hit the pause button. We're gonna open it up to questions. We can talk more about COVID trends as they've happened this past week. But I wanted to bring this out as something that's very important because we know this will be impactful to our workforce from this point forward and perhaps well into next year and the years to come, because opioid addiction is something that lingers for quite some time unless treatment and interventions are become more prominent in the workplace. So with that, we'll stop and we'll open up the questions. Thank you.
Thanks, Dr. Harris. We have very many questions yet, so please go ahead and use the Q&A function on any topic related to COVID, and we'll jump right in. People are reporting side effects similar to COVID symptoms from getting a vaccination, typically symptoms 24 hours. However, if employees have COVID symptoms, we have to quarantine for 7 to 10 days. How do we differentiate between vaccine reaction and possibly be infected with COVID? Can we assume the symptoms? Am I breaking up?
You are breaking up, unfortunately, here, so I missed a good chunk of that question.
Can you see Q&A?
Say it again.
Can you see the Q&A?
Yeah, let me pull it up and see if I can.
Because you can look at the question.
All right. Okay, I see it. So people are reporting side effects similar to COVID symptoms for getting vaccinated, typically symptoms for 24 hours. However, if employees have COVID symptoms, we ask them to quarantine for 7 to 10 days. How do we differentiate between vaccine reaction and possibly being infected with COVID? Can we assume the symptoms are from the vaccine and that they don't have COVID from a recent exposure? Great question, and the answer is complex and case by case, right? So we can't make a blanket assumption for any individual that has received their first or second dose of the vaccine and had a reaction or response to the vaccine itself. Now, just the first lay concerns, having a mild fever, having body aches, and mild syndrome, if you would, after a vaccine can be normal, not necessarily an adverse event, right? That's part of the body responding appropriately to the immune challenge. However, when we're talking about distinguishing that response from COVID-19, typically, again, it's a case-by-case determination, but typically, if there are no known exposures for that individual and the only potential change in their kind of daily regimen is the vaccination itself, it's likely to be the vaccine causing that, as long as the timing is appropriate, right? So again, case by case determination, but for example, someone receives a vaccine, let's say their second dose, and on day 8 begin to have symptoms, it's unlikely at that point that it's more associated with the dose of the vaccine versus some other type of illness, respiratory illness, if they're having a cough or rhinorrhea, a runny nose, right? It may represent a cold or even the flu, but again, it should be a case-by-case determination of, is this person presenting with some type of infectious upper respiratory or some type of viral syndrome or predrome, if you would. Now, when we talk about whether or not they should quarantine whenever they have a response to the vaccine itself, the appropriate answer is yes. Now, whether they need to quarantine for 7 to 10 days, no, right? We want to make sure we're appropriately keeping people home until a case-by-case evaluation is conducted, and we do that in conjunction with your provider. Obviously, if you are utilizing work care services, we have our clinical staff, our physicians that do the evaluation with the individual over the phone and can quickly make a determination of what the next best steps are.
Great, thank you, Dr. Harris. This is Alexis Lupo. I'm actually going to be finishing up for Karen today. So I'm going to ask the next question. Have you heard of Moderna COVID arm, and should the employee get their second dose in the other arm?
Sure. So the Moderna COVID arm essentially having symptoms from the injection in the arm that received the Moderna vaccine, right? And the symptoms can be quite significant in terms of pain, swelling, redness. Those are all symptoms of and side effects from a vaccine challenge, right? And when we talk about the most significant of these type of reactions to the utilization of that arm. It's something that can be associated just with vaccines in general and not specifically with Moderna, which is basically a frozen shoulder, okay? And typically what has happened in that scenario where you have a severe reaction in the shoulder and the actual capsule of the shoulder is that the administration of the vaccine perhaps was done in a way that was a little too deep to the muscle tissue. And it's a known phenomenon that unfortunately I've taken care of several times from just flu vaccinations and other types of vaccines administered in the deltoid of the arm. Okay, so the ability for the individual to get the shot in the same arm or whether they should get it in the other arm is still up to them, right? In terms of providing them a disability, particularly of both arms, is a risk, right? That they have a response in both arms. So you need to consider that if you are having a significant response in the Moderna quote unquote arm, to weigh whether or not the shot should be administered in the contralateral arm, the opposite arm.
Okay, someone wants to know if you can take Advil prior to taking a COVID vaccine without diminishing the effects of the vaccine.
Correct. So the vaccine should not be affected from an efficacy standpoint using over-the-counter anti-inflammatories. So that should not be a concern.
Okay. Do you anticipate that the CDC will expand testing recommendations to include screening of asymptomatic or employees at random? One of our attendees was reading an article about people who have O-type blood type and may have some immunity to the COVID virus. Do you have any comments on that, or have you heard of that before?
So for the first part of the question, in terms of screenings or surveillance testing of asymptomatic individuals, that may be required for many of the workforce, right? We know and are working with several employers that are requiring for all of their US locations, those who are showing up to work to undergo a surveillance test once a week for COVID. And that is starting immediately. So that trend may continue here as we continue throughout the year and more people come back to the workplace. What we are looking at in regards to Otype blood and the evidence thereof with regard to protection, some level of protection to COVID-19 infections, we presented on that topic last summer, and the evidence was supporting that individuals with Otype blood may have some immunity to infections. And we can, if you review our FAQ, or you should, or our Q&A, excuse me, you can reference the specific increase in protectionism, if you would, for O-type individuals. There were 2 studies that looked at the O-type individuals compared to those with other types of like A and AB blood types.
Okay. How long do you have to quarantine after receiving the vaccine for a 62-year-old previous cancer patient?
Well, that's a very specific question, and the answer may vary, right? So if the individual depends on the individual's specific scenario. If they are symptomatic because of their pre-existing condition longer than a typical course of COVID-19 in an otherwise healthy individual, which is about 14 days, right? Then they may need to quarantine for longer or isolate rather for longer if they are symptomatic. If they are asymptomatic, then their quarantine period should be on par with just the general public's quarantine period, which again, recommendation now is 10 days after an exposure or 10 days after onset, 14 days, excuse me, after an exposure or 10 days after a positive test or onset of symptoms.
Okay, that's all the questions we have for today. If anyone has any additional questions or topics that you'd like us to cover in the next couple weeks, feel free to email myself. Thank you so much, Dr. Harris, and thank you everyone for attending today.
Excellent. Hey, thanks everyone. We'll see you next week. Until then, stay safe and God bless.